Hi. So this is my talk on pulmonary interventions that I'm going to give on Saturday at the Crossecon, and I thought I'd just put it here so that there is a ready reference for those who want to see it before or after. So this is a 69 years old who came with a right upper lobe mass, and we can see the mass. It's big. It's almost 5 centimeters, and it's should be very easy to biopsy. It shows uptake on PET. There's no significant necrosis, so we can biopsy uh, any specific focus. So there was a large pleural tag, and I thought it would be nice to go through it, so that would reduce the chance of a pneumothorax. And so I decided to biopsy this in the left lateral decubitus position, right side up, left side down. We have to go through the pre-procedural checklist. So all of this was taken care of, reviewed the referral note. There was no other study, not on antiplatelets. We knew it was for histopath and micro, and nothing special needed to be done. So I decided to use an 18 gauge BARD with a 20 millimeter throw to get as much tissue as possible. And so I was going to be easily within the lesion. So now during the procedure, you just have to make sure that you check whether the positioning is correct, recheck consent. So I take the consent anyway. IV access, we don't nowadays do atropine, and make sure that everything is ready. And you can check this out in this URL here. And the study started, it was going quite well. I was inside the lesion within about 2.5 minutes, deployed the gun. But then the patient landed up with a pneumothorax, and I was scratching my head because entry pneumothoraces are not really that common. Pushed it further in, then again it bounced back out, and now you can see that the edge of the gun is actually in the pleura. That's my deployed gun. That's the stillet here. Sorry, so the cannula, not the stillet, the cannula. Sorry, the edge of the cannula is in the pneumothorax, and that's the gun here. Then again pushed it in, finished the biopsy. After that, I withdrew the cannula, aspirated the air, and most of the air came out. Then did a rapid rollover, and you can barely see any air. And then 7 minutes later, there's no pneumo. 1 hour later, there's no pneumo. So what had happened is air had gone in, and I was able to remove it. Post procedure, um, we followed her up for an hour, and then gave them instructions for bed rest, etc. Met the patient before they left and made sure that all the requisitions were properly given and all samples labeled and sent. Working diagnosis was adenocarcinoma, which is what it turned out to be. And that's the summary. It took 16 minutes because of the aspiration. Otherwise, it should have been done in about 12, and 5 course for histopath and 2 for micro. Now, what had happened is that if you see the Cook gun, there's a 4.2 millimeter extension beyond the cannula, and the cannula is round, whereas this is a beveled edge for BARD, and it's a 7 millimeter extension. So I need to make sure that when I see the entire assembly inside, I account for another 7 millimeters when I remove the stillet. So here I am, and when I removed the stillet, the cannula was at the edge because there's that 7 millimeters. So I should have been in another couple millimeters. At the edge, the air went in because I wasn't completely inside the lesion, and that caused the pneumothorax, and that I aspirated. So I'm showing this case to demonstrate how simple lesions sometimes can become complex, and that in a biopsy, even the mechanical aspects of the gun, the tray, the size of the stillet, where exactly you position the cannula, all of these matter. So today we'll talk about biopsies and ablations. Let's start with biopsies. We need to follow the checklists, and I showed you that in that case, and make sure you protect yourself, the patient, obviously hit the target and get answers. Protecting yourself, that also involves protecting the patient, is to prevent bleeding. Make sure you know what is to be biopsied, be ready with all materials to manage complications, do a detailed consent and counseling, and in a private setup, have a second hand, someone who knows how to manage complications. How do you prevent bleeding? INR should be less than 1.5, platelets greater than 100,000, stop clopidogrel and equivalents for 5 days. Just no compromise here. Stop the NOACs for 2 to 3 days. Aspirin, I'm old school. I like aspirin off for 5 days as well. Just be a little careful with CKD patients. Even if their INR is normal, sometimes they can bleed. And should you do tranexamic acid prophylaxis? I do it in every patient because the downsides are minimal unless the patient is CKD, and the upsides are significant. Now, here is a patient. I've gone through this vessel here, biopsied this patient, bled, and then there is significant bleeding of up to 300 cc. There is nothing you can do about it. You're completely dependent upon the body's ability to stop the bleeding, but bleeding stops on its own if coagulation rules have been provided. In the end, there'll be tamponade because of the hematoma, and the bleeding will stop. I use tranexamic acid liberally, as I've said, and then sometimes if there's bleeding. And very rarely do you need to hospitalize. It's been about twice in the last 15 years. And again, the patient basically was fine. We were just doing it to be a little extra careful. Consent and counseling perhaps is the single most pre-procedural thing that you can do. And you can see the entire video here, but you have to explain the procedure to the patient, explain the complications and how you will tackle them, explain breathing patterns, and be in touch with patients and relatives. Manage complications, manage pain. So this is protecting the patient, but again, it's part of protecting yourself. I've just artificially divided these different things. Now, complications, the main complication apart from bleeding that we're really worried about is pneumothorax. And this is when we're doing lung biopsies. Now, pneumothoraces can be entry, as I showed in the first case. To reduce that, make sure you reach the lesion with a single pleural puncture. When you have subpleural lesions, make sure you angulate and traverse a little bit of lung. It's a little counterintuitive, but I'll show you an example, and avoid a transfissural approach, and obviously avoid cysts and bullae. For an exit pneumothorax, to prevent that, withdraw slowly, do a rapid rollover, or you could use blood, gel, saline, etc. to seal the tract. Now, this is an immediate subpleural lesion, and what typically will happen is, because the edge of your cannula will be sitting at the lung pleura interface, there is a high chance of creating a pneumothorax. Whereas if you go through a little bit of normal lung, then that chance reduces. Now, this patient has bled a little. If you allow, and if you withdraw slowly and the blood comes out from the lesion along the tract, it seals the tract, and so that would reduce the chance of an exit pneumothorax. I like the rapid rollover puncture side down. For me, that works very well. So as soon as the biopsy is done and I remove the needle, the patient is turned over in a matter of 10 to 15 seconds here, and that pretty much seals the tract physiologically. And sometimes you may have about 5-10 cc of air that comes out during the maneuver, but then it doesn't increase. And this is how you do it. The patient is prone. I've finished it. You always do it in a way that the side doesn't rise up. So you have to intuitively make sure that if it's the left, then you go along the left side. If it's right, along the right side. Quickly roll over, and the patient has become supine. But it has to be very fast as soon as you remove the needle, and not something that is done at a leisurely pace. If the pneumothorax happens, manage it. And I showed you that in the first case, but here's another patient. Again, it's because the lesion is touching the pleura. There's an entry pneumothorax, and this clearly has happened because the cannula was probably in the pleura and the air just gets sucked in. So I withdrew the cannula, aspirated the air, pushed the tip inside a little more, finished the biopsy. This was another patient with a dysplastic lung lesion where the same thing happened, but because there's a lot of peri-lesional cystic change, I was not able to aspirate it. So then it kept filling up. So I put a tube inside, finished the biopsy. Remember, the patient has come to us for the biopsy. So if it is possible to treat the pneumothorax easily, then it's also a good idea to finish the procedure. Pain is something we radiologists don't seem to tackle well. But remember that often the only thing the patient remembers about the biopsy is whether the patient had pain or not. So use liberal local anesthesia. I also anesthetize the pleura lung interface. So you have to bring the needle just close to the pleura and then inject 10 cc of lignocaine. That also helps to seal the tract later. But there's only one paper that talks about that. But nevertheless, it helps to make sure that the patient experience is good, and patient cooperation will be much better if all of this is done. Very rarely, because in the lung you want the patient to cooperate with breathing, I try not to use sedation, but sometimes conscious sedation helps. The next thing is to hit the target, and this then becomes a question of expertise, of learning how best to get the needle into the lesion. And the way to do it is to start with larger lesions, which are very easy to do, then move on to less, to smaller lesions, so 7 to 5, and then 2 centimeters, and then here you move to 8 millimeter nodules. And today I can, in the right patient, do 3.5 and 4 millimeter nodules if required, but it's taken a while to get there. And that's a good way to get your hand used to doing these biopsies. I do all of these in free breathing because it really helps to control where you're putting the needle. So here is a patient who has multiple lung nodules, and as I say, multiple nodules are a curse, because if you have one nodule, you will find a way to get to that nodule. When there are multiple nodules, you have to scratch your head and hope you're choosing the right one. So I finally chose this one here in the left lower lobe, and I decided to do it in the right lateral decubitus position, left side up. And you can see that the patient's breathing is a little off. So here I am injecting the local anesthesia at the lung pleura interface. Then I've gone in, still the nodule is a little off. Now I can see the nodule. I pierce it, not sure. So you have to withdraw it, and you know you're in the nodule. Withdraw it a little more and then deploy the gun. And that's the gun that's deployed here. You have to make sure you withdraw it a little when you're springing it, because there's a vessel here, and then you biopsy it. And then it immediately, the cannula bounced out because of the force of the throw, and then you have to reposition it again to get a second core, but that happens as well. And again here, you can see the cannula at the edge, and the gun through it and through the lesion as well. So free breathing allows you to do that. If you're going to tell the patient to hold their breath each time, you will waste a lot of time. Also, the patient gets tired and is never able to hold the breath at the same level. Use the shortest route possible. And that's very important. I don't talk about air embolism because for whatever reason, I haven't really experienced that in the last 30 years. And that normally happens when you have a bronchovenous fistula. And so people will sometimes tell you to use all kinds of stupid routes where the lesion remains, below the left atrium, but it's not required. As long as you don't go through major vessels and plan your route accordingly, the shortest route also becomes the fastest, and the faster you are, the less the complications. Angulate. if your machine is able to let you angulate. So here's a nodule in the upper lobe, the rib is here, 5 degrees angulation, clears it, and then you can go in and biopsy it. Change the arm position. Sometimes it can be as simple as that. So here's a patient I'm biopsying in the decubitus position. The scapula and the rib both come in the way. So this was the arm above the head. It worsens. I push the arm in front and I've got a straight track that goes in, and I finished the biopsy. PET-CT helps in multiple ways. It helps you target the most active area. It also tells you which areas to avoid. It also sometimes shows you other lesions in the body that might be simpler to biopsy. Now, this patient, and the general rule we have is always biopsy the periphery because the center would be necrotic. This patient has pneumonia type invasive mucinous adenocarcinoma. And funnily, the active area is in the center and the periphery is not. So the patient had one biopsy which was negative because the earlier radiologist followed that rule, which is the right thing to do. But then I knew that this was the active area, so went into the active area and biopsied it and proved the diagnosis. And you can use multiple tricks in the same patient. 71-year-old, lots of vessels here, ex-smoker, didn't really want to go through lung. So put the patient in the prone position, but the rib is in the way. So the first thing was to change the arm position so the rib is cleared. Then I decided to create a selinoma with hydrodissection, hoping that if I can push the pleura out, I could actually take an extra pleural approach. So I'm liberally injecting a combination of saline and local anesthesia. And this is, you angulate it towards the spine so that you create a lot of space. And then I reposition the needle. You can see that here. So now this is a separate access that I'm taking. But there is an aorta here, and I just want to make sure that I am clear of the vessel. Even if you're 1 millimeter clear, that's enough. And here I am. And here at the skin surface, I'm angulating the needle laterally so that, and I've given contrast, so I know where the aorta is. I enter in, I have enough clearance, and then I go in deep enough so that there's no chance of injuring the aorta or the pulmonary artery here. I'm well within the lesion, and then I can biopsy. So even though it looks like the cannula is touching the aorta, that's not an issue here at all because you're way beyond. The tip of the cannula is at least half a centimeter away from the aorta here, and that's good enough. And you have to get an answer, right? So that means you always biopsy, never FNAC. And I thought this debate was over about 10-15 years ago, but I still see places where FNACs are done. Just don't do them. It's not worth it. You need to use a gun cannula technique. You need to get a lot of samples. Do not split the histopath samples among multiple pathologists because then you don't have any leftover for further testing, and if the results are different, it creates a lot of confusion. Typically get microbiology for TB in our country in all patients who are not known malignancies, and you should follow up your path and microbiology reports. Have a system in place, some assistant, some sister, some receptionist whose job is to do that, so you know how you're doing, what is positive, what is not, why did you fail. Talk to the pathologist. Sometimes just talking to them changes how they word the report, etc. So the gun cannula technique is a coaxial technique. That's a 20 gauge cook. You can see the stillet inside the cannula. That's the gun. When you're inside, you remove the stillet so the cannula remains inside. And once the cannula is in, you hold it with one hand steady. With the other hand, you can keep pushing or putting the cannula inside, the gun inside the cannula, and take as many cores as you want. So in the lung, I will use 18 to 20 gauge, 10 to 20 millimeter throws depending upon the situation, and use the largest gun you safely can. Sometimes if I'm taking material for molecular analysis in a known malignancy who's already had a prior biopsy and therefore now is tuned to it, has also gone through chemo, maybe radiotherapy, there if you use a 16 and if you've primed the patient for a possible complication, it's fine because the aim is to get a lot of material, and the patient will also be okay if there's a complication because now they're already used to a bunch of procedures being done. Then let's talk about ablations. And ablations, there are three main techniques: RFA, microwave, and cryo. And these are the differences. I asked Claude to create this. So RF, microwave, these are no-brainers. I use liquid nitrogen for cryo. These are the different ways in which it happens. This is the equipment, that's the ablation zone, and this is the way the monitoring happens in real time. So you really are just dependent upon the impedance and calculation of power and time. Cryo is the only one where in most instances you can see the ice ball, so you know exactly how much you're ablating. RFA is no longer done as much as it used to because SBRT, or radiotherapy, has taken over in a big way. Having said that, the data isn't all that great, different. It's just that the radiation oncologists are more powerful. They've got more studies in place. But otherwise, when the earlier studies were done, we know that RFA, microwave, cryo are equally good. So you can do that in primary lung tumors less than 3 centimeters and metastases less than 3 centimeters. You can do curative ablation and ablate multiple lesions. And it has similar results. So here's a 56-year-old post-chemo residual tumor in the perihilar region, went in with the umbrella electrode, the multi-tined electrode, and you can see on the follow-up study that the lesion is now completely inactive. This is another patient who had metastatic adenocarcinoma. That's the zone of ablation. It's like doing an extended resection. When you have a zone of ablation that's 1 centimeter thick, you know that you've ablated all the margins, and this is curative. Now, you can do multiple in the same sitting, and I had this patient who had four nodules, and three of these I could do in the prone position, as you can see here. I think the whole thing took about 2.5 hours, but the ablation was good, and these have been successful on follow up. This nodule, they then decided to wait and watch, but it increased in size on follow up, and then went ahead and ablated it. And you can see the zone of ablation around the nodule of almost a centimeter. Therefore, you know that you've ablated it well. Microwave is also a technique you can use, but I'm a little wary because you need to have at least a clearance of about 15 millimeters from the pleura. And then you have to give yourself another 15 millimeters to do it. So these are technical issues, and sometimes you have something called a burn back where the burn goes all the way up to the pleura and can produce a lot of pain. And you can see that here there is some amount of reaction in the pleura with the zone of ablation here, because if the zone of ablation is going to be concentric, then it's involving this part of the pleura as well, and this can cause significant pain. If I had to do this again, I would probably just do radiofrequency ablation. Anyway, the zone of ablation is clear, and this patient on follow-up had no disease at all. I haven't done cryoablation in the lungs. It's simply because microwave and RFA are such good techniques for small lesions in the lungs. Then the cryo needle, the smallest is 13 gauge, that I'm a little wary of putting that inside the lungs. But this is what an ice ball looks like. This is a recent patient with a neck mass from synovial sarcoma that I did a palliative ablation for. And this was a psoas met that I did a curative ablation for. And this needle here is for hydrodissection of any nerve that's coming out here. So you inject warm saline to make sure that the nerve and the vessels don't get injured. But I did do a pleural lesion. So this was a patient who had a dry pleural met from, you can see that here on the PET, from thymoma post-surgery. And here we thought cryo would be the best bet. So I went in here. You can see that. You can see the zone of ablation. Now, because of the density of the lung and the nodule, I couldn't really see the ice ball very well, but I could see the zone of ablation very well. And then on follow-up, the patient came back a year later. There's nothing. The entire lesion is as if vaporized. All I can see is the fat of the retropectoral region, which is filling up that gap. And this was extremely satisfying when I looked at it. So the idea was to talk about biopsies and ablations, with the idea that you must follow the checklists. That's very important, and I have another snippet on checklists which you can go through whenever you need to revise all of that. But that helps you protect yourself and the patient, and it allows you to take care of your two main complications, that's hemorrhage, preventing it and taking care of it, and pneumothorax, preventing it and taking care of it. And then you have to develop the expertise to hit the target in the best possible way, and make sure you have a way to follow up your patients to get answers. So once you do all of that, you will be able to both ablate and so once you know how to put needles inside, you can easily ablate any lesion as well. So then you should be able to do biopsies and ablations very well. Thank you so much for viewing this.